Good evening, everyone. Thank you very much for joining for an exciting evening. It's going to be our first combined cardiology and cardiac surgery grand rounds. And on behalf of myself and my co-moderator, Dr. Mark Russo, we are really thrilled to have a world-renowned personality who's giving the grand rounds lecture, Dr. Michael Mack. But before we go into that proceedings further, I'm just going to provide a little bit highlights of what has happened in the last several months. The grand round started last year, 2021. There have been 37 talks with 32 external speakers. And what was very exhilarating is to see this amazing response on the recording we have received. There have been, one of the talks has received over 1,000 views, and that was from Dr. Muhammad Al-Kuli, and that's the future of interventional cardiology that was recorded last year. And similarly, there have been a couple of other which have exceeded 500 views. There are 24 talks with over 100 views. So I think the whole objective of trying to get the educational sessions designed so as to create a dissemination beyond the walls of where we are confined now is probably coming true. And what we have also been able to provide is 506 CME credit and 264 maintenance of certification credit. And for today's grand rounds, please go ahead and open your cell phones and text 17013 to the number 888-816-4893 for getting your CME credit. And this will be made available to you also online as a recording. And you'll have a deadline to do this CME visitation within 12 hours. It should be an SMS message. And for physicians who are aspiring to have the maintenance of certificate scored here, please go ahead and complete the CME, and then you'll have an ability to get an MOC points also. If you go on this link, and we will try to get you this link either by email, or you can use your mobile phone and take a picture. You can scan it. I'll give you a minute to just scan it. And once you go into this link, there are Q&As. If you answer them correctly, you'll have to use the code future38 to get in. And once you answer them correctly, your maintenance of certificate points will directly integrate into your ABIM ID. So once again, your CME and MOC points are based upon these two items. We will go ahead and provide that also as a link. I'm going to now invite Dr. Russo to introduce Dr. Michael Mack.
So in my world, at least, Dr. Mack's someone who needs no introduction. He's director of the cardiovascular service line for Ballard, Scott & White, which is that 50 hospitals, Mike? How many hospitals in that? It's a huge hospital system in Texas with at least 7 active cardiac surgery programs. Dr. Mack has served as president of almost every important organization in cardiac surgery, including the Society of Thoracic Surgeons, which is the largest society of thoracic and cardiovascular surgeons in the world. The Southern Thoracic, ISMICS, the Thoracic Research Foundation, and you're the vice chair for the ABTS, which is the American Board of Thoracic Surgery, which is obviously an important role and a big honor. He was a prolific clinical surgeon. He has made important contributions in terms of moving technology forward in research. He was one of the leaders for the Syntax trial, for the partner trials, the entire series, co-apt. A couple of fun facts about Dr. Mack is you're boarded in both internal medicine and cardiac surgery, right? So fully trained internal medicine doctor. He also he and I also went to the same high school. But Dr. Mack, by my estimation, is probably the most influential cardiac surgeon, certainly in the U.S. over the last 10 years, if not the world. He's, again, somebody who moved forward technology, advocated for the heart team approach, was a leader in shaping education, and has been a great mentor and advocate for an entire generation of surgeons like me. I'm sure he's probably the most impactful person in my career. And so it's an honor to have him here.
You can advance with this if you like, or you can use the hours, which always easier for
Well, thank you very much, Mark, for that overly kind introduction. And he only said those nice things because I did go to his high school just a few years after him. I mean, before him. But he also outed me as that I'm not a native Texan, because we know Mark didn't go to high school in Texas. So this is actually Christian Brothers Academy in Syracuse, New York. And you know, they describe you a native Texan as anybody has been there one day longer than you. So I have been in Texas long enough now that I am really a native Texan. And like they're fond of saying now, I wasn't born there, but I got there as soon as I could. And also my memories of growing up in Syracuse, New York, is that all our summer vacations were in northern New Jersey. Nutley, Passaic, Belleville, all our relatives lived there, and our summer vacation was going into Yankee Stadium to Yankees games. So I've always had a fond place in my heart for northern New Jersey, although I'd never been to New Brunswick before. So it's a great to be here and an honor. I go back a long way with both Mark and Partho, and it's great to see the institution and all the exciting things that you're building here. And it's an honor for me to talk about this. This is actually a talk I hadn't really given before. And Partho insisted that he didn't want to hear another device talk or a surgery talk or a structural heart disease talk, but he wanted to, what appealed to him, this idea of a cardiovascular collaboratory, organizing the intent to impact the outcome. So he picked that title, I didn't. And I hope that I live up to his expectations of what to hear from this talk. Or the other way I would have said it is how we can all work together to improve cardiovascular care. This is my conflict of interest disclosure. I've been in the leadership of a number of trials in valvular heart disease and structural heart. So first question is, which is your heart team? Everybody has a heart team or says they have a heart team nowadays. Is it this or is it this? Is your heart team real, or is it just a checkbox that you say that you have it? And I think that too often it's the latter. It's just a checkbox. Everybody says we work together, but the functionality of it sometimes leaves a lot to be desired. So a little bit of history of the heart team. It actually was a concept that was operative in the 1950s at the Mayo Clinic. This is Robert Fry, a long-term professor of medicine and cardiology at the Mayo Clinic. Surgeons would meet with the cardiologist outside the patient room, discuss the case, and then the two clinicians would walk together as a manner of good conduct. Then I lived through the era in which all that fell apart. And it was in the early 1990s, and it was the introduction of PCI into coronary revascularizations. And it was before stents, and it was where there was just plain old balloon angioplasty. And there were a lot of dissections, and I spent a number of years taking patients, pumping on their chest to the operating room for an emergency bypass of a vein to the LAD that was all dissected. And there was a lot of consternation, shall we say, between the two specialties. And that created a very divisive work environment. And kind of what happened is that there were two specialties at a tug of war with each other, with the patient caught in the center. And oftentimes clinical decision-making could be defined as the shootout at OK Corral. And the result is, if you don't work together, oftentimes you end up with something like this. So the idea behind team-based clinical decision-making is, rather than one horse pulling the load, if everybody pulls together in the same direction, then it's a better outcome. So I think too often the current healthcare system is a siloed approach to care. And this is our heart hospital in a Dallas suburb. And too often a patient's treatment is determined by which door of the hospital they enter. If they go into an interventional cardiology office, PCI may be the right answer, or a general cardiologist that listened to the ischemia trial, medical therapy. Or if a surgeon's office, well, cabbage surely's got to be the right answer. Or if it happens to be a surgeon that knows how to do a robotic Lima to LAD, then that's clearly got to be the answer. It could be a TAVR, it could be a SAVR, could be a mitral valve repair or replacement if a surgeon's not proficient at repair, or TEER if they walk into the mitral valve clinic or an interventional cardiologist's office. So none of this makes sense. That your care should not be dictated or predicated on whose office you walk into and who you see. I mean, we got to find a better way of doing it than that. So this is Steve Jobs' a biography that's probably 10 or 12 years old right now, but this always struck out to me. I realized that I was facing the type of problem with my oncology care that I never permitted at Apple. My treatment was fragmented rather than integrated. Nobody at Stanford seemed to be in charge of figuring out how nutrition was related to pain care and oncology. I was being treated by all these specialists and ologists, but not being coordinated in a cohesive way. So he convened the team of various Stanford specialists at his house to coordinate treatment. Well, there's a couple things there. One is this is an outsider business person's view of how we deliver healthcare. And it's a very sobering assessment of it. Secondly, he's probably the only guy in the world that gets all the specialists to come to his house. And I'll bet they all showed up too. So there are predecessors of the current heart team, and it's been a fact of life and practice for decades now of oncology tumor boards and heart transplant teams. Mark mentioned the Syntax trial and the partner trial that I was involved with both. So the tumor board has been, for decades now, multi-specialty shared decision-making between surgeons, oncologists, radiation therapists. And now it's even more heightened with immunotherapy kind of really impacting significantly oncology. Trying to figure this out makes cardiology and cardiac surgery easy. Heart transplant teams and liver and lung transplant teams, of course, have for decades functioned as the best way to figure out patients with advanced heart failure disease. So this is the Syntax trial leadership that met every 3 months for 7 years in different hotel rooms, hotel room basements, conference rooms around the world, to manage the syntax trial. And it was an equal balance of surgeons and cardiologists. And I must say, to this day, a number of these are some of my closest friends in the professional world. One of the consequences of that syntax trial was the creation of the modern heart team, I would say. Because what happened is, in order for a patient to be considered in that trial, which is a randomized trial of CABG versus multivessel PCI for either three-vessel disease or left main disease, is both specialties had to say that the patient could be revascularized adequately by either approach. So it meant that both specialties had to look at the angiograms together and go talk to the patient together. And what it required me to do is, oftentimes I had to scrub out of surgery in the operating room to go to the cath lab and say, yeah, I think we can bypass this patient, or no, not. And so no, I can't, or vice versa. And so this is our chief of cardiology, David Brown. And this was us in 2005 screening a patient for eligibility for that trial. Our relationship preceded that, in that I put in my first and only LAD stent in 2002. Now, I didn't do it because I felt the world needed another interventional cardiologist. We were doing robotic Lima to LAD in the animal laboratory, and I needed completion angiography at the end. So it got to be easier to do that if I learned how to do it myself. So I went up to the cath lab, did 20 left heart catheterizations. About the eighth one needed a stent, and the chief of cardiology insisted I put a stent in. And so 10 minutes later, I deployed my first and only LAD stent, and I said, now I get it. So the lesson there is to understand how another person thinks, walk in their shoes. And this was a life lesson to me right there from this totally unanticipated experience. That further led to collaboration between the specialties, in which we worked on the TAVR in conjunction with the heart team of cardiologists and surgeons at Leipzig, Germany. This was a time that there was not TAVR in the United States. There had been an initial try at doing TAVR in the United States. There were a total of 7 cases done at Columbia in New York and at William Beaumont in Detroit. And 5 of the first 7 patients died, and the trial was put on hold in the United States. And so there was work done on figuring out another approach than the original approach, which was a procedure that in retrospect could only be done in France. So we went to work on a transapical approach, while John Webb in Vancouver was working on the transfemoral approach. But the first procedures that we did were done in Leipzig, and Leipzig is where Goethe wrote Faust, and Mephistopheles is still in the beer halls there. And this is our first human cases of the transapical in 2004. And the deal we did with the devil was Alain Cribier, who was the person that did the first human with it. So this was a very collaborative approach. And he came from Rouen, France to Leipzig, Germany, solely to help us on our first cases. And it was a signal of the way that this field was going to evolve from thereafter. And so this was our first patients in the partner trials. All those patients had to be done by a cut down at the time. And this is, again, Dr. Brown and myself doing the first partner trial case in the United States in 2006. And this was the further collaboration. This was a of surgeons and cardiologists that ran the partner trials for a 10-year period of time between 2006 and 2016, again, that met 3 times a year in order to manage that trial. And again, very close friends from that period of time. Now, if we go back to the syntax trial steering committee again, I want to highlight 2 people from that. One is the circle on the left is David Holmes from the Mayo Clinic, and the one on the right is me. And by serendipity, we became presidents of the STS and the ACC at the same time. We were friends through the syntax trial. We became close collaborators, and both societies worked closer together to construct the whole paradigm of the heart team. In addition to that, while we were presidents, we got approached by the FDA. This is Jeff Shuren, who is he still is the director of the device division at the FDA at the time, and said, we are about to approve this new procedure called TAVR. Would the professional societies be interested in helping the FDA roll this out to the United States? So this led to the collaboration between the professional societies and the FDA, which again has continued today. This is Bram Zuckerman, who many of you know, who is the head of all cardiovascular devices that are approved in the United States. And it continues to be a robust collaboration with the FDA today. Now, this led to what's called a national coverage determination, which is the conditions for payment of TAVR. And this was a approval of reimbursement for TAVR under what's called coverage with evidence development, which led to the TVT registry that we use today. But it also codified this concept of a multidisciplinary heart team. So you don't have to do either of these. You don't have to enter patients into a registry, or you don't have to have a heart team, only if you want to get paid for it. So it was a pretty powerful stick to be able to mandate this. But in many ways, I felt it's kind of a shame that government, both FDA and CMS, are the ones that are forcing the heart team concept on clinical practice, that we couldn't do this ourselves, that we have to rely on our payers and regulators to say that this is the right thing to do. So this led to the TVT registry, which now has over 400,000 TAVR procedures in the United States. But I bring it to your attention because of this publication that came out of it, of what this is: a new model for medical device innovation and surveillance. And this is not one of the journals that I know I read regularly, called Health Affairs, but it is the Bible that Congress and other branches of government use to help dictate healthcare policy. But look at who the authors are on this paper. It's two professional societies, the STS, the ACC, it's the FDA, it's CMS, and it's industry, all that kind of got together in a collaborative approach that serves as the healthcare policy for how reimbursement is going to happen for procedures in the United States and how it's going to be monitored. And this serves today as the main mechanism by which medical devices are approved. But I bring this out to show the collaboration between this diverse group of stakeholders. And this has led to a number of publications regarding the heart team, evidence-based approach for the heart team, a number of concepts. And so everybody is saying this is a good thing, but it's hard. It's easy to say, hard to do, and hard to figure out. So this is one of our multidisciplinary team clinics. And we make it work, but one is the logistics of how we do it is always a problem. And the second, how do you demonstrate value? How do you do a randomized trial between a heart team and no heart team and say the heart team's clearly better? It's kind of like motherhood and apple pie. I mean, it feels right. It sounds like a thing to do, but how do you prove it? It's pretty impossible to do. But despite that, it is a class 1 recommendation in all of the guidelines. Doesn't matter what you're teaching, what you're treating in cardiovascular disease. This one's valvular heart disease. It's a class 1 recommendation, but the level of evidence is C, which means a CEO means there is no trial evidence for it. It's just expert opinion. So again, it's being widely adopted, but there isn't a strong body of evidence that say that patient care really is better for it. So I use this as an example of how we do it. So this is one of our multi-specialty disease clinics, and this is surgeon. We have aortic valve clinics, we have mitral tricuspid clinics, we have thoracic aortic clinics for complex ascending arch and descending thoracic aortic disease. We have advanced heart failure, mechanical circulatory support clinic, and then we have a cardiomyopathy clinic, which is HOCM, amyloid, et cetera. And our first one was aortic. This one here is mitral and tricuspid. And we have all multimodality imaging displayed for everybody to see it. We usually divide into 2 teams. We have an interventional, we have our imaging specialist there that educates us as to what we're seeing. This is surgeons, interventional cardiologists, advanced practice practitioners, and research coordinators. And this is a summary. I just gave the example here of our clinic last Thursday, our TAVR clinic, in which we saw 4 new patients and 4 reevaluations. And this is the summary that comes on each patient before they're ever seen. This is the workflow of it. Is we have a patient comes in the morning. They get all of their testing done, including repeat of outside echoes, CT scans, frailty testings, 5-meter walk test, frailty testing. And then the patient's seen in the afternoon by multiple specialists. The patient makes one trip, gets all the tests done, and by the end of the day, they've seen all the specialists and a decision is made for them. And we've done this since 2007. So that's going on 16 years now. And it's still a work in progress because everybody's torn in so many directions. And only one person gets paid for seeing that patient. There's only one RVU encounter generated. But we've all bought into this because we figure this is a better way to do things, and what comes out of it benefits the whole institution. We're better for it, and we now have a program that does 2,000 open heart operations a year. We'll do 450 TAVR procedures a year, and so we think it's an investment well worth making. So the pros of doing a multidisciplinary heart team clinic are it's very efficient. All testing and decisions made in one day. The patient seen together by all specialties, so it helps keep everybody honest and not overpromise the patient that they're going to do great, go home the next day and have no complications. And there's team camaraderie. There's no turf issues. That everybody, it's a esprit de corps that doesn't exist, I'm convinced, without doing it this way. The cons are it's a long day for the patient and family. We think we're so efficient getting everything done in one day. They have no concept that how much they actually got done. All they know is their 88-year-old grandmother spent 10 hours at the hospital and had a lot of time waiting. Only one provider generates RVUs, and logistics are a constant challenge. So we have kind of taken this concept and expanded it system-wide. And as Mark said, we're part of a large healthcare system called Baylor Scott and White Health, which has 8 cardiac surgery programs and 6 TAVR programs. And we took one of our interventional cardiologists and one of our cardiac surgeons to create a system-wide TAVR program with the concept of a rising tide floats all boats. And the stimulus for this was when national public reporting was going to start for TAVR. We wanted everybody to be a 2 or 3 star program. So we put together a collaborative for TAVR. We subsequently have done this for mitral valve disease now to figure out surgery versus MitraClip and try to have some implementation of optimal guideline-directed medical therapy for secondary MR. And we also are doing this for system-wide CABG now at the same time. We also have a system-wide ECMO collaborative. But these are the 6 programs, and you can see the number of folks engaged from each of these 6 programs. It meets on a monthly basis. All outcomes are tracked. All mortalities and all strokes are discussed together. And this gives you an idea of the spectrum of institutions, and this is through 2021. And we have large volume and low volume institutions. So a total of, at that time, 5,200 TAVR procedures done. Our institution had done 2,300 at that time. We have the smallest institution had done a total of 104. We did 329 in 2021. The smallest one did 44. So you can see a wide spectrum of experience and procedural volume. So we went through a number of quality improvement assessment from each of the institutions. One institution didn't have a great CT scanner. Another, the heart team model wasn't fully operational. Some didn't understand how to fill out the TVT registry correctly. So a number of things were put into place of standardized processes to make everybody a high quality program. And then we have standardized pre-procedural workup, intra-procedural management, post-procedural care, and then mortality risk reduction strategies. And one of the biggest was figure out who was too old, too frail, of so-called cohort C. A patient was dying with aortic stenosis, but not from aortic stenosis. And so this has been in since 2019 now, and this is the results. So the dotted line across the center is the 50% benchmark of the TVT registry in terms of 30-day mortality. The yellow line, the heavy yellow line, is our healthcare system. And the other lines are all the individual programs. So in 2019 or 2018, our overall TAVR mortality was 3.2%. Now, some of it got better just by the fact that low-risk TAVR got approved. And so the risk profile of the patients came down. So you can see it came down from 3.2 to 2.2. The black line is where we started this collaborative intervention here. And you can see all comers, the whole healthcare system, the overall TAVR mortality is 0.6%. So we cut mortality by 70% due to this establishment of best practices. No pride here. Nobody's preaching to anybody else. Everybody's just trying to get better and be proud of the program. And I think this speaks for itself. And this has now been, this actually will be presented. It's been presented at the NCDR Quality Initiative, and it's being presented next week at the ACC meeting. So I want to move on and in the time remaining, talk about how this has gone to a national collaborative basis and called a national collaboratory. So this is an article from Jack last December of 21 that talks about the Heart Valve Collaboratory and shows the multiple stakeholders that are involved with it. So the way this started was the FDA in January of 2020, just as the pandemic was beginning, approached Marty Leon and myself and said, will you consider co-chairing a new collaboratory with the FDA in valvular heart disease? So our response was, first, when the FDA asks you to do something, the answer is always yes or hell yes. And second is, what's a collaboratory? We thought it was a made up word, but it actually is a real world. And if you go to Dr. Google and look it up in Wikipedia, it's a center without walls. It's a virtual collaboration laboratory, an empirical research environment in which scientists work and communicate with each other to design systems and participate in collaborative sciences. So the Heart Valve Collaboratory was founded, and I must say this is one of the positive benefits that happened from COVID. I think if COVID didn't happen and the world didn't transition to a virtual environment for a couple of years, this concept never would have gotten off the ground. But the mission statement is to advance the health and wellness of patients with heart valve disease. It's a patient-centered, multi-stakeholder collaborative community established to identify knowledge gaps, catalyze research, build consensus, and support the development of evidence to inform healthcare policy and to advance innovation. And the vision statement is a collaborative, multidisciplinary, patient-centered community of stakeholders addressing complex problems and embracing innovation. So this is the Heart Valve Collaboratory website. We have a vision, a mission, a vision, a website, but most people still don't quite understand what it is and what the reason for this organization exists. So what is it not? It is not a society. It doesn't get involved with guidelines. It doesn't have members. It doesn't have large scientific symposia. It doesn't do advocacy. No special relationships with our branches of government. We're not a CRO or an academic research organization, and we don't fund grants. We also have no access to, nor the capacity to develop new and novel medical technologies, and we have no special industry relationships and avoid getting in between different industry sponsors in the medical disease space. So in other words, we're Switzerland, or try to be Switzerland, where everybody can work together. So it's a not-for-profit public-private partnership between two research institutes, Cardiovascular Research Foundation and Baylor Research Institute, and the FDA. It's multi-stakeholder by intent, and the goal is to collaborate with everyone. Patient-centric and ecosystem focus. And the idea is we're trying to catalyze projects and get together different stakeholders that ordinarily would not interact with one another. The way we think of it is we're kind of interstitium or connective tissue with a purpose, and filling knowledge gaps and bringing people together to address the most difficult issues, and issues that wouldn't be addressed if these stakeholders didn't come together, and to be able to find the funding to be able to do it. So what is it? We enjoy addressing important, complex projects, and I'll show you some of these in just a minute, that others have declined or relegated to orphan status. Committed to diversity and proper balance in activities in clinical research, mentorship of early career faculty, and process methodology and implementation science is a key part of this. So it's run by a scientific council, and these are the stakeholder groups that are involved with it. It's clinicians, the FDA, industry, Medicare, the NIH, and patient advocates, and translate all this into meaningful activities. There's 27 members of the council that run this, and it's co-chaired by Dr. Leon and myself, as well as the FDA. And you can see there's general cardiologists, heart failure cardiologists, imaging specialists, cardiac surgeons, interventional cardiology, and trialists. And then great representation from the government, including the chief medical officer of the coverage group at CMS, NHLBI, patient advocacy, and then the four major industry sponsors in the valve disease space. And so this was, as I mentioned, this wouldn't have happened if it wasn't for COVID. And the first time we ever met in person after now 3 years in development was in Washington at the end of January. And sitting around this table in this room are three branches of government, patient advocates, the Duke Margolis Center for Health Policy, industry, professional societies, and academics. This is some of the activities that have happened. We have had 10 think tanks now, which have all been virtual, that have brought between 60 and 100 multidisciplinary experts from around the world in 2-day virtual seminars that have happened. We have addressed a number of knowledge gaps or facilitation projects, health policy projects, and developed consensus documents and manuscripts. So this is the first thing that happened in 2020. We had a virtual workshop on the effect of pandemic on cardiovascular research. It was the first one of these that have been done. There's subsequently multiple papers on this. We have also put a global think tank together on bicuspid aortic valve disease. Then in 2021, 2 research consortiums on mitral and tricuspid valve disease. The tricuspid valve disease has gone a long way already to inform the FDA about parameters for approving and Medicare for reimbursing tricuspid valve disease later this year. And then projects with the FDA and industry on polymer valves, as well as other aspects of valve sizing. In 2022, we had 3, again, virtual workshops, one on aortic regurgitation, one on pediatric heart valves, and one on patient-reported outcomes, because patient-reported outcomes is going to increasingly be used as a metric for FDA approval, as well as a metric for reimbursement. And those project leads for those are the experts in the field of patient-reported outcomes. And this is what one of the think tanks looks like. And again, you're able to gather people from all over the world. If you ever tried to do this in person, it never would have happened. You couldn't get this. You couldn't get these types of individuals. But whatever specific area you're involved with, you can get all the experts together over a 2-day period of time in 2 4-hour sessions. These are the think tanks that we're doing in 2023. One is looking at a redo TAVR, which is becoming an increasingly problematic problem. The second is medical therapy to slow the progression of aortic valve disease. And this is both addressing the valve and the ventricle. And some of it is to try to slow aortic valve disease from progressing before. And second, as I was talking to Partho before, I think we're going to be able to get a trial started looking at SGLT2 inhibitors post-TAVR and post-surgery to look at if you can improve left ventricular function afterwards. And then the third one is going to be the role of AI and machine learning in valvular heart disease. And project lead is going to be Patricia Benettini, who is the head of this at NIH. And I'm hopeful to recruit Partho to head this one up for us also. So there have been a number of science sharing seminars that the FDA has put on with engineers and experts in terms of bench science, in terms of valvular heart disease. As you can see here, each of these was attended by 200 participants from around the world. Other projects that we're doing is suitability for TEER, and I'm not going to read all of these to you, but it gives you an idea of some of the concepts. The second one from the bottom is development of a global heart team academy. This was brought to us by a number of Europeans, and is probably the one we have struggled with the most of, as I alluded to earlier, how you develop evidence and how you standardize this practice across multiple healthcare systems. One of the major projects now is creating a pragmatic clinical trial platform to conduct pragmatic trials. Everybody's talked about doing this across the United States, and nobody has been successful at this. This was an article that was published in the end of December in JACC in the European journals talking about the need for pragmatic clinical trials. So we're taking this on and see if we can create the infrastructure for it. One of the things that we've been able to do is to decrease the case report forms for the TVT registry, which is a constant pushback from all the clinical sites, how burdensome that it is. And we were able to work with the professional societies and decrease that case report form. We've been very involved with Duke Margolis, which is a Health Policy Institute. Mark McClellan used to be the head of CMS and the head of the FDA. And we've been very involved in public comments for national coverage determination, as well as hosted a series of 3 think tanks with them on the development of real-world evidence for tricuspid valve devices that are going to be approved later this year. We've had 7 consensus documents published to date. And we've got another 7 that are in progress in virtual areas of this. So this is all in a 3-year period of time. So the first 3 years was an intense virtual experience, exploring the boundaries of collaboration laboratory model to unravel many of the projects and largely representing short-term, low-hanging fruit to demonstrate that we could work together and accomplish something. We had limited resources, good intentions, loose governance, but we learned many lessons during the pandemic virtual phase, and that is bringing these virtual think tanks together of global experts and giving input into healthcare policy, of being able to be at the table and not just being on the menu when the government makes these decisions about how we deliver care here. That's been very refreshing, to be honest. But we need to make this sustainable, and we need funding to do that. But the FDA was correct. There's a need for a differentiated organization that focused on identifying knowledge gaps and addressing complex ecosystem, applying multi-stakeholder collaboration and principles. And I am going to take just an aside here to give a shout out to the FDA. I must say that I always thought of both FDA and CMS as faceless and nameless bureaucrats that were working on a government salary to do a job that they could go home early, and none of them could make it in clinical practice. It's not the case by any means. These are absolutely incredible individuals that try to do everything possible to introduce innovations safely to patients in the United States under the constraints of what they can do by government law. And this whole collaboratory concept was the FDA's vision that made this happen. The whole heart team approach, the whole generation of evidence for TAVR, the whole randomized trial concept was all FDA's vision on this. And so I'm a huge fan. So now we're working on the creation of a national network of sites for pragmatic clinical trials and to foster best practices, including heart teams and quality improvement initiatives. So I think to explain that just for a second, there are now 820 TAVR sites in the United States. And we know who the 3-star programs are, and we know how the 1-star programs are. So the question is, there's no remedial action by which you close the loop for quality improvement. So it doesn't do you any good to know you're a 1-star program. How do you make it better and become a 2-star, 3-star program? So we're putting this network together that can do quality improvement. So I showed you what we've been able to do in our healthcare system standpoint. If we can scale that up to a national model, then we can be like Lake Wobegon in Minnesota, where every child is above average. That's the goal here. And also we can get these sites to work together to answer simple questions that won't be answered by industry regulatory trials or NIH funding. So in summary, collaboration on multiple levels, I think, really can make a difference in patient care and care delivery. None of this is easy. Cross-fertilization between multi-stakeholders is key, and it's actually fun. So thank you for having me, and I think we're going to have a panel discussion right now, Partho.
So I'll invite Dr. Enrique Pantin. Has he joined here? Oh, yeah. So Dr. Enrique Pantin will join us on the panel. And this is for an open discussion, but before people can pose question and the panel can feel free to pose question as well. I would like to start off by, I think there's a microphone there. I'd like to start asking the panel, and particularly Dr. Mack, is I think when the TAVR started, given the complexity and from where it has gone and what it has become, given the workforce shortage that we are experiencing in terms of number of people we train in either of the discipline, what do you think is the future in terms of the collaborative being armored equally with all number of people? And what does it mean in terms of efficiency? Do you think there could be alternative paths that could emerge? I mean, we know that we have started well. Is this sustainable?
So, turn on. Once again, I'm a surgeon. So I think one of the great things that has happened, fostered the collaboration, is doing procedures. And I must say, I got involved in this early on because I knew TAVR was the real deal, but I had no concept how big a deal it was going to be. If you look at all isolated aortic valve replacement states today, 85% is talking about TAVR, 50% was. New procedure came in. The overall mortality of all TAVR, all in the United States is 2%. The same as what it is. The original coverage decision was written so that there would be a maximum of 500 centers. And it turns out there's now 820 centers with outcomes like that. I never would have predicted. So, one of the concerns right now is that actually constraining access to care. That I have these criteria in place. So I was wrong in thinking that this. So second is how easy the procedure, not dismissive of the operator requirement of operator expertise required for the procedure. But it's much simpler than doing a requirement has always been 2 operators, 1 surgeon, 1 cardiologist. You really need only 2 operators, 1 operator. So this has been a subject of cardiology meetings. I don't need you anymore. I can do it by myself. I say that tongue in cheek, but realistically, when research or the resource aspect, it probably needs to progress to that. However, on the stress strain on the collaborative relationship and begin to understand issues that have happened over the coronary revascularization that has served as a negative between the collaboration to be another one in terms.
100% true. The part of the procedure is no longer the procedure. To make you wonder, particularly when you talk about your what there needs to be more focus on is the front after rather than in the room. Years that was really the focus. But you cover the sort of the next iteration of likely those number 8 as create capacity so that programs are 300 I think those are the challenges.
Want to add also there are some key components, and we see that our cases that it must be there present. Those need to be fine. We have this side one, like industry, partner with them. They're a key element. Very constant element that we have to maintain our audit. And you see as an example, now non-cardiac anesthesiologists are doing procedures that before we just cardiac doing things that otherwise didn't do before. Expanding to the clinical care anesthesiologist. And I think in this regard too, it will continue to practice. And we should actually work on training the rest of our colleagues because there's no way around it. And we should probably just help them get there safely.
Yeah, and particularly when in my previous institution and now and also here, when it comes to dedicated imaging specialists and structural space, it's very difficult to recruit dedicated people who are trained. We have more number of interventional structural people trained than number of imagers who have been trained. And I was looking at your room with all the. I think that's not the case most of the places across the US. And I've seen general cardiologists are getting forced into to learn how to image TAVR and or clips and so I think there is a certain degree of concern, particularly for bigger health systems or larger hospitals, and the workforce structuring. And I think that there must be some degree of thought given on how to structure the future workforce so as to be making it sustainable. And also inclusion of mid-level providers, nurse practitioners, paramedic. I mean, we have to have a certain degree of redundancy in terms of support staff. And that is not easily expendable, but at the same time is required.
Two comments there. The first is kind of a downer. So research, and Mark, I'm sure can, that in a number of the smaller institutions undergoing TAVR, the important role of industry, main procedural brains. Operator will show up in the morning, say what size you make sure you don't put it too low because and well, it's sobering. Second, I would say is that the role of so many times over the years before we ever one of our APPs that'll say help you bigger.
offering restriction ever. The patient doesn't want it, the family wants it, the patient just wants to go home and out her day. So don't you dare think you're doing it. Don't listen to them because they're always right.
Or APPs. I don't know if I can not hear that they're actually over here. Okay. But yeah, it's absolutely true that I don't, as far as industry role, I don't think that's just in call centers. And, you know, it's a little bit, in some ways, the industry people operate effectively in some kind of case and other, you know, other. And they're imaging is really the bottleneck, particularly in mitral disease. And it's how you see mitral and tricuspid progressing and how it's different. You know, everyone expects it to be the next tab of it.
You're right, and the big point is, one is for mitral, it's not one disease that has, it's not a simple valve that has one disease. Slam dunk, 20-minute, put it in, you're done type thing. Don't think that TIR or trans. Also not sure that replacement is going to be. Yeah, it's like flying a plane in the most. Telling you where you're going. And you put it on steroids for tricuspid. Tricuspid is actually easier technically, but see it, it's easier to do than mitral. Multiple times, inside or outside, and it's not just patronizing by any means, but most out. Both in pre-procedural planning, for procedural and post-procedural assessment.
No, the only thing is that, I think, which for many of us has been. Models or some rigid models, that area can be hindered. I think taking the opportunity, we have experts, on our local teams is very important. So, some aspects are more important than others, of course.
Questions from the audience? Any to the panel? Any other questions? I wanted to ask you. So the heart team meetings that you do, given the complexity of life and people traveling from different places and different location hospitals, how do you end up getting them into one room? It's tough. But what's the alternative? I mean, what I'm saying is like, do you do it virtually or how do you do it?
So we did it virtually during the pandemic. On that, as soon as we, like everybody else, developed the telehealth option, but as soon wanted to come and be seen in person, so we're back full time. All of them, our infrastructure and our providers. If somebody needs an additional PPE, just so a patient can get two trips. And something else I was gonna say, but
Where do you modernize? I mean, getting patients on their-
so the short answer to that, watching is gonna be the easiest to HydroClick has got. As we talked about earlier, a lot of times those patients can easily go home the same day. I think that on the road to be able to do.
Yeah, and there was one more question I wanted. So I know that team dynamics play a very important role. Do you do any team building exercises? What do you do?
So you just reminded me of the other thing I was going to say. So as well as seeing patients together in clinic, Monday morning, every Monday morning, we have a routine clinic or have a meeting that we review all the outcomes from the previous week. Of about 10 TAVR procedures. We've all previous weeks reviewed and all the upcoming. Mitral tricuspid, everything. High risk for anybody that's high risk. That means PCI stent. I mean, supported angioplasty. Things with an STS risk of over 5% is all presented in the multidisciplinary team clinic. Now, discussing ordinary revascularization. And that was that our surgery mortality plummeted to under 1%. Well, just because we turn it from surgery, so we go. So that, you know, which is in terms of team building aspects, we did it a lot early on. We didn't. And Mark programs bringing. Nothing like getting to know people side of work. Something very well. Actually, some of the things that we actually did. You know, turn out to be great team building exercises. All members of the team.
Any other comments or any? Yeah, yes.
You know, I did something in Boston before I left with, you know, on space, kind of like the COVID
So cath lab, IR, endo, OR, everybody. We didn't call them ORs because our biggest challenge was the cardiologists didn't want to do it, that they didn't want to be any time. So we figured out the best way to do that was the backdoor entrance for the cath lab. That's actually what made it happen. So we moved forward. I think the unrecognized advantage of this integrated platform, we didn't call ORs, not everybody go to the same place, and the collaboration that happened, that collaborative. I think that was being predicted was all the nurses now had to learn how to recover all these patients across cover. So unlike many hospitals, there's still some silos, people suffering in the same nights or the same place. Have a room in the future, where would it be? How would you play access? Would it be in an OR? Would it be in a cath lab? Would it be in a separate location? Perfect location.
I think you're asking an important question where how do you, I don't know if it's so much that you want to have all the procedure rooms together, but just like if you're talking about, integrating with third line or having an institute, there's proximity is important, right? If you put separate people, I mean, I expect them to run up and down the stairs between rooms. It puts the stress on that, and it also reduces the opportunity to collaborate. I mean, I have the unique opportunity to collaborate with cardiologists and OR because I go to cardiologists who are involved in medical procedures. That's really the great piece. All of it was important.
Because that would be the ideal scenario. I would really love that for multiple reasons. One, integrating for other services, cardiology, medicine, pulmonology, people that participate in our. I've got nursing, you are nursing, and my one people nursing, and the kind of nurse. Or we should do, but basically close. Foster relationship, I think will be a big improvement. And increasing complications. There are many things that doctors like I learned. I don't always remember this in the cycle, but the first time I saw cardiology put like 3 or 4 lines in the groin. It's like, why can I do that and connect? So that I put 3 or 4 introducers and stuff. I learned that from cardiology, watching what you guys do, and only because I have been tuning the same thing. So we can all learn from each other. It'll take another 10. So my market should be in an area we can all learn. There's still something to be said about who's sure. The way we started it with hybrid operating. But we do one day a week we do it at lab. And maybe a way I would have ORs and cath. Sounds like a great solution, but
Very good. Yes, Anthony.
Thank you for your presentation. In the name of centers of excellence, reconcile the need for procedure. Every center be doing everything, or should we focus? Texas, large, New Jersey, small. Thank you.
So, critical question miserable, but actually is the key. Find quality with access to care. And we so this idea of the collaborative. Like to think about it, if you could walk in and one of those programs. Some rural Texas or what we strive for, but as much and when I started running our service line, there was no certificate. And there were 34 heart surgery programs. Surgery programs, the whole country. I mean, I had 14 cardiac surgery programs. The problem is with doing that, it's not like all those patients now come into the center of excellence. They'll come in, they go to that across the street. So I think you realize that based upon patient's idea of house, we have patients that want us coming from state that want to stop and pray and don't even want to sit. Standpoint. So it's hard to translate that outcomes maybe more experience centers from that standpoint. So I think you're always kind of have to be the one. Said earlier, already have it 800. Always have to try to balance quality. Constant dynamic trying to. I also think the same thing for coronary intervention. I was for years against standalone PCI. It turns out to be totally safe and all by the way if you have busy words. Okay, to treat STEMI and transfer patients. So that's a complicated way of not answering an unanswerable question, I guess.
I think that's exactly right. It's just like looking at restaurants. It's easy. Have to know what it is that you're serving. Popularity, but there's still significantly less than 500 cases reported. 248, right? Probably 200 paper print time. That's years. And so, that's not something that's going to be done. 100,000 average done in the U.S. and you can imagine.
Stop along the
What all those things? I think it's more. I think doing a clip is not so much from a procedural standpoint, but I think the limitation is what we're doing. For the limitation for Michael, transcatheter Michael therapy, the limitation on images more so than I can. My 10-year-old, that's not rocket science. Right? The hard part is understanding the views, making sure you get the things you need. And tricuspid, the procedure, at least the tricuspid replacement, the procedure is actually kind of important. It's all about having pre-procedure planning and procedural imaging. And actually, probably the pre-procedure part is the most important. Cancer limitation there is appearing. Yeah, I can't imagine hundreds doing that. So, and not be able to manage. So, highlighted it.
I think that this is really the future and might be an imaging technique.
Yes,
How the whistle is creating something inside the heart, so we can look at this on March there, it tells him, move to the right, starts dying and the way is
so I think the question that you're raising is what is the future looking in terms of innovation? I think there is no question that one of the challenges has been the standardization of the images and the interpretation measurements, and AI is there already there, and we have already spoken about tools that can really standardize and identify these patients quickly earlier and improve the. I think the biggest challenge in structural procedure, as was being alluded, is not the procedure per se, but get the right fit and the right timing. I think most of the time we get this patient so late, so that's a bigger challenge. And in imaging, there is no doubt that there's a lot of AI and efficiency will be offered, and there's technological evolution that is happening. CLIP is probably a transient phenomenon, and some of the difficulties that we're experiencing with imaging with CLIP. In fact, I would have to say very openly, measuring the success of CLIP is very challenging, because when you call something mild, moderate, sometimes we take the consensus, the difficulty. So there is a lot of ambivalence also in the field, and it's a complex technique and a complex endpoint to achieve, and you have to balance out a lot of things. But in place of that, once we have more definitive and deterministic outcomes with the transcatheter mitral valve replacement becoming a little bit more commonplace, maybe there'll be a easier ability to image and reach the endpoint that we're looking for. But I think it's probably time. It's late. It's been a fantastic day. We had the great opportunity to spend almost entire half day with Dr. Mack, and the time to look through the innovation. This is a very evolving field. Whatever we are talking is probably going to be changed, and there will be new techniques and points, procedural guidance that may emerge. There's a strong enthusiasm. This is a complex area. There is as was pointed out, as much as we are looking for the quality, at the same time, we are looking at access. So all of these discussions probably are going to be extremely critical as we design the pathway forward here at RWJ and Brunswick and within the health system. But there's no doubt that collaboration will be important, but also recognizing that future may be different, and the ability to work in different roles, yet be able to look at the outcomes more coherently is going to be needed. Well, thank you very much. I'd like to thank the panelists and Mark and Ricky and Mike for spending the day. And hopefully we'll see you again and look forward to having you again. Thank you, everyone. We take a picture.